to hit record.
I'm sorry. I didn't know you wanted it to be recorded just yet.
Somebody's gotta remind me. Anyone, it's so bad. I can't. I was supposed to see if I could change a setting to make it automatically record. But anyway, anyone, just remind me if it's not recording. It is right now. Does it send you a little thing that says it's recording, hit OK or something like that when I record, right?
Yeah,
So
to continue or to leave the meeting.
Yeah, don't leave. All right, so let's go back. Share. Okay, I think I got it. All right, so let's go over that chapter 1 quiz. I think it's pretty, well, you guys ended up having able to do multiple attempts for that, so I won't do that for the next one, but anyway. All the following are examples of symptoms, except which one? Which one's not? What do we call C?
Sign.
So what's the difference? Yeah, what's the difference between a sign and a symptom?
A sign is like what's actually happening, and a symptom is what the patient or what the individual is experiencing.
Yeah, and so when you say, yeah, a sign is what you as a clinician can actually observe or measure, right? But symptom is, right, what the patient is feeling, right? So you don't know if the patient has numbness, they have to tell you that, right? You don't know if they feel nauseous, they have to tell you that. Okay, so make sure you understand the difference between the two. All right, and if there's more questions on anything here, just let me know. Blank is described as the number of new cases of a disease or condition within a defined period and for a defined population. So which term means new cases? Incidence, right? As opposed to prevalence, which is just the number of cases. So incidence is the number of new cases. And it goes along with epidemiology, right? We talked a little bit about that. There was a whole little section of the chapter that talks about the importance of that. And I think we talked enough about that. All right. A disease with an unknown cause is called what? Idiopathic, right? And I think I asked you guys this before. I mean, would you, a lot of diseases are of unknown cause, right? So you could probably make a general statement and say that most diseases are idiopathic, okay? All right. All the following are examples of modifiable risk factors except what?
Race.
Race. Yeah.
And so, and then again, I can ask you if you're going to distinguish between modifiable and non-modifiable, what's the difference? How would you explain the difference?
One is changeable and the other one is non-changeable.
Good. One is, right, you can change on your own. You have the ability to change, and the other you don't. I think we also talked about like examples where you could come up with examples of where like maybe diet isn't necessarily modifiable by the patient, right? Or it's not very easy to modify it. What did we say about that?
Like a baby.
Yeah, a baby.
Baby, people allergies.
Say it again.
People allergies.
And also like people in like I'm hearing echo. But people who have like low economic status and they can't afford something different.
Yes. Very good. Yeah. I don't know what all that feedback was from, but it went away. Yeah. All right. Cool. Blank is a disruption of physiologic or psychologic function.
Disorder,
right? So it can be, we can talk about a psychological disorder or a physiological disorder, what have you. If we talk about chronic versus acute, what do we mean by that? I'm sure we all know this.
chronic is long-term.
And what about acute?
Appears quickly.
Yeah, and goes away quickly usually. And it's usually like if you think of injury, right? An injury is usually acute, although it could lead to chronic issues, right? But all right, practice decisions should be based on research studies that have been evaluated by using a set of consistent criteria. True or false?
True.
And what do we call that? Chrysanta, what do we call that? It was like kind of like the heading for like the last part of the chapter 1.
Pathophysiology.
Nope.
Mm.
Starts with evidence. Remember, evidence-based practice. Yeah? We remember that term? So just know what it means. Essentially, it means that.
No, I didn't get.
Health is considered absence of disease. True or false?
True.
Kind of like a, I don't know. Obviously, it's very simple statement there, but yes, true. Remember we talked about like the continuum, kind of this health and wellness kind of continuum, right? Or health and illness, where, you know, you can be super healthy over here and then like very ill over here, and there's lots of in between. Okay. All right. Blank is the study of functional alterations at the molecular, cellular, tissue, and organ system levels that are involved in disease states. Chrysanta, what's that answer?
Pathophysiology.
Yeah. Pathophysiology. All right. Which one of these is an example of a chronic disease?
Empathy. D.
Yeah, D, emphysema, right? Upset stomach, common cold, strep throat. These are all acute, short-term diseases, right? Whereas emphysema is a chronic, long-term disease. Which affects what system does emphysema affect?
I think it's the
Respiratory.
lungs.
Your lung.
Yeah, lungs, respiratory system, right? Yep. And what's the most common cause of emphysema?
Smoking.
Focus.
Smoking, yeah. All right, blank is an individual's subjective experience with disease. What's this one?
Illness.
Illness.
Illness, right. Remember we talked about that if we talk about illness, again, it's how the patient feels, how ill do they feel, right? They could have a disease, but feel well, right? So it doesn't necessarily, I guess having a disease and being ill don't always have to be together, right? And vice versa. You can not have a disease but feel ill, right? All right, so let's make sure that we got 100. Otherwise, I better go fix it. And we did. Okay, so everything looks fine. So any other questions about chapter 1? I think chapter 1's super basic and pretty straightforward. Again, mostly kind of like terminology. But I don't think it's too bad. Any questions, guys?
For the evidence-based practice, you just have we just have to keep in mind that even though new research does come out and new things are available, we have to take into consideration all the other factors for the patient.
Right, exactly. I mean, and it could also even be taking into account financial resources that your hospital has or something, right? So right, there's a lot of, so it's not necessarily that you're oh, we definitely have to do this, right? Sometimes it may not be best for the patient. You may not have the financial resources. Maybe the staff isn't trained in that yet, right? So there's lots of other factors, but yeah, that's correct. Thanks for bringing that up. Any other questions that have to do with chapter 1, guys?
Yeah, I have a question.
Oh,
Go ahead.
Go ahead, Erica.
can you explain the difference between a syndrome and a disorder?
So a syndrome is where you're going to have multiple sort of systems that are going to be affected that all sort of comprise that. I mean, again, some of these terms, right? Things like disorder and syndrome and stuff like that, I feel like those are sometimes kind of used interchangeably. It's kind of like that idea, right? With kind of illness and disease, though technically they're sort of different. A lot of times you're going to kind of see overlap in the use. Okay. So it's not, I don't know that it's super important to sort of harp on those really distinct differences between the two, right?
Okay.
There's similarities. Yeah. Go ahead. Who else had a question? Marianne?
I had a question. So I might be looking into this too much, but for the idiopathic, where it's you have a disease, but we don't know what caused it. Are we talking about what caused it inside of the body, like what happened to lead to that, or are we talking about like your kind of decisions? Like with the I think emphysema, we said smoking kind of caused that. So what are we thinking, or is it like both?
No, I think that's, I don't think that you're thinking too much about it. I think that makes sense. I mean, when we say it's idiopathic, so for instance, I'm thinking of like diabetes, for instance, type 1 diabetes, right? We know that like what happens, there are genetic factors, there's probably environmental factors that come into play, but basically what happens in the body is that for some reason you have an autoimmune response that's attacking those cells that produce insulin, right? But we don't know why that happened, right? We know that there's these factors, but we don't exactly know what caused the body to mount that immune response to then attack those cells. Do you know what I mean? So that's kind of where the idiopathic or the not knowing part comes in. We do know like that it's those cells that are affected, right? But we don't know what caused it. If we knew what actually caused the body to mount that response, we could just reverse it, right? But we don't know that, and that's true for most of them. Does that help? I don't know. That's the one example I thought of that might make kind of the most sense. With things like emphysema though, yeah, smoking is like number one. However, there are cases of emphysema where it's not smoking. There are people that smoke that don't develop emphysema. Does that make sense? Right? Think about it that way. People that could, smoke for 40 years and they never developed it. So it's not the only cause. Again, these are all there's always these sort of multiple factors that are going to contribute to it. When you talk about something like, Down syndrome, right? Purely genetic disease. We know the cause is trisomy of chromosome 21. We also, though, don't know what then caused that genetic change. But in that case, you know that the cause is that genetic change, right? That then leads to all those other deficits that you see in the sort of the clinical manifestations. So again, nothing is really clear cut, right? I mean, I think that's true about anything in science and medicine. Nothing's really sort of clear cut, but that's kind of, I don't know. I hope those examples kind of help. Does that help a little bit?
Yeah, they did. Thank you.
Okay. Mm-hmm. Other questions, guys? Marianne, did you have a question?
No, I didn't.
I thought you did. Okay.
Professor,
Chrysantha, go ahead.
there is about latrogenic. They said it caused an international. I didn't understand about that.
Say it again. For iatrogenic,
Mm-hmm.
which is caused by
An international.
a what?
I think she means unintentional.
Yeah. Meaning that it's a mistake, like a medical mistake, right? So think about it that way. So you go in for a surgery and somehow they make a mistake during the surgery that then causes disease, right? Or causes, yeah. So it's an unintentional, obviously nobody's gonna purpose that, but it's unintentional by, think of a medical professional. Yeah. Caused by some sort of medical procedure or something like that.
Okay.
All right. Other questions? Trying to think if there's anything. I'm just looking here. I think we kind of hit on all the main points. I think you guys got it. All right. So let's move on. Okay. So what we're going to do is we will go over this chapter 2 case study. That's not the way I needed to do that, actually. Let me not do that. Let me go back here. I had it all ready to go. Where is it? Let me make sure my e-text is still here. 1 second. Of course not. To go away. Oh no, you got to be kidding me. Oh, I thought it wasn't going to let me show you. Sometimes it does things like that. Anyway, okay, so that's still there. I just want to make sure that was still there. Yeah, I'm going to pull the case study up this way so that I have all of them in the PowerPoint. So then that way we can look at another one as well, because there's one that I want to look at. Okay, so we were doing the case study on Bianca Vasquez, correct? Is that true? You guys all agree?
Yes.
Yes.
Hopefully that's the one you guys submitted. All right. So if we, and the other thing is too, like some of these questions, it's kind of like, I don't know if you remember like our lab manual freshman year where it's kind of like asking the obvious, super obvious questions. Well, that's true about these sort of case study questions. But regardless, it sort of prompts us to talk maybe a little bit more about it. So I think, so anyway, and sometimes too, there's not like a right or wrong answer in terms of how you're answering the questions, right? There could be multiple answers. All right, so hopefully we read this here. Okay. About Bianca Vasquez, she has food allergies, right? She's pregnant and she's concerned about her newborn. All right, I'm just reminding myself of this. Okay, so number 1 asks, what is epigenetics? So what did you guys write for that? How'd you define that in your own words?
Oh.
Mariano, I hear you. Do you want to answer that?
I guess.
That's epigenetics. You should know it from cell bio too. Come
Yeah,
on.
yeah, yeah. I got it. It's right in front of me. It's just you said it in my own words. I got it from the slide. So let me put it in my own words.
Just pretend you remember the things that I tell you guys.
No. I literally have it right in front of me here.
What's epigenetics? How are you going to define it?
Well, what I have here is what I have from the slides, but you said put it in my own words. But what I have is an external modification that allows gene expression.
Okay, well, that causes changes in gene expression, right? Okay, so where are the changes? Are the changes in the DNA sequence? Somebody else answer. If you say epigenetic changes.
No.
No. It's an expression.
In things like, like methyl groups that might be added to the histones or methyl groups that are added to the DNA. Those are the types of changes. Who's Mariano, do you have your cell phone on? Who has a cell phone and their computer on? Somebody? If you do, that's where the echo's coming from. It doesn't.
I mute myself every time I'm done speaking.
It's not you. Okay. So just be careful if you do that. It goes super crazy. Okay. So, all right. We all know what epigenetics is. All right. So number 2, what advice might the genetic counselor give Ms. Vasquez about news reports of genetic breakthroughs? Oh, this is kind of like advice that I forewarned you when we talked about like journal articles, right? What do you think?
To make sure she's reading credible sources,
Okay.
because
Yep.
there's a lot of pseudoscience going around. So
Yeah,
sure.
especially these days, right? Lots of that. So yeah, that's good. So something along those lines. What else? Somebody want to add to that?
I said that, like an advice that she might give her, well, like my first reasoning is that the sources that she's reading from might be false, so she shouldn't go by it.
Mm-hmm.
And yeah, that was one of my reasons.
Right. And so,
And-
go ahead.
Oh, I also mentioned that she should probably check like journal articles or like research papers about that specific
Okay.
or about like epigenetics to kind of get her information from there instead of from the news, because they don't explain everything. They just tell you the headlines.
Okay. So you bring up a good point, but do you think that a patient with a non-science background would be able to really read a journal article?
No.
Not just that, but like each person has their own genome, so she might not need the medication that she wants to. So whatever she's listening, whatever she's seeing on the news cannot apply on her specifically.
Right. So I guess the point, Rachel, that I was trying to make is like you as the genetic counselor or you as the nurse or you as the doctor, right? It's probably your responsibility to translate that scientific and medical information into layman's terms to explain what you guys kind of just brought up, right? And like what Fabi was alluding to is kind of saying, well, although some people, kind of that this increased polysaccharide, whatever, might affect them, that's not necessarily true always for you, right? And so the idea, so probably not the best idea to like refer them to the primary literature, but it's your job to be aware of that, right? And then give the information to the patient. Does that make sense?
So in essence, this was a trick question.
I mean, I guess it's not really a trick question. I think the idea is to tell her that those news reports aren't always accurate. And you could say, if you really want accurate information, maybe you go to these journal articles, but you may say, hey, they may be hard to understand. Here's what I think, or here's what the real information is. Do you know what I mean?
I also gave an example, like, to wait till the baby is born and get the baby checked out for like allergies and stuff like that, because I know you can do that.
Yeah. And maybe not to worry so much, right?
Yeah.
I talked about like how gestation and neonatal stages are like really vulnerable. So possibly like take the pills there, but still not like confirmed that it'll actually help, but it is a high chance.
Yeah, I mean, and potentially if you take too much of anything that's, even if it's a good thing, right, it could potentially be harmful, right? So, you know, I'm sure the genetic counselor will probably say, hey, talk to your doctor, right? But maybe I wouldn't advise you to take that or something like that. But like I said, if you're specifically focusing on this, it's what you guys just said. The genetic counselor should say, hey, that stuff that you hear in the news isn't always necessarily true. And then you could mention the journal articles and kind of say, this is where we get our information from, but that patient probably wouldn't really be able to understand what's in there, right? But your job to then educate them a little bit more. If you look at the answers that the book provides, it says, Ms. Vasquez should be instructed to speak with her genetic counselor before making any dietary changes based on news reports, right? Or speak to her clinician, not only the genetics counselor. So yeah, so I think you guys all got that. All right, so let's move on, if it lets me. Oh, cool, I went twice. Okay. Okay, so this is still kind of the same thing we said before, right? Further understand the underlying mechanisms of fish oil use and why results of taking fish oil supplements vary from person to person. How can the study of pharmacogenetics help Mrs. Vasquez reduce her baby's risk of inheriting allergies? So this is kind of like, again, I don't know. I mean, they don't mean her studying that, because that's probably beyond or a little bit over her head, but maybe not. Maybe she's a scientist, right? So you got to kind of know your patients. There could be patients that can understand journal articles, right? They could be clinicians themselves or scientists or something like that. Then you can refer them, right? But what'd you guys put here for number 3?
I said that the pharmacogenic, whatever the word is, will look at specific genes to check like whether or not she should take like certain medications.
Yeah, so I guess what do we mean by pharmacogenetics? How would you define that?
So what I wrote was that pharmacogenetics is essentially looking at how like drugs or drug therapy can affect the individual's genes and their genetic makeup. And so what I answered for this question was that the genetic counselor specifically should let her know that the supplements that she's thinking about taking can have different effects on her, and they can have different effects on other people just based off of their individual genetic makeup. And that if she has a tendency to have like overt inflammatory responses, that maybe for whatever reason, like this supplement could cause that or could elevate that in her case.
Right. Yeah, I think that's good. That's a good answer. Really good answer. What else? What are some other things that you guys wrote down?
She could visit a pharmacologist who specializes in this area, and then from there she can like receive testing to see how it affects her.
Might respond, right?
Yeah.
I mean, and so that's the idea, right? Remember, I gave you guys, I think in the recorded lecture, I gave this example where, there are certain people who get this abnormal response to anesthesia, right? And you don't know that until you go for surgery. And then you could have this, sort of severe response that could cause you to essentially die, right? Or go into respiratory issues. But there is a genetic test that you could take to know if you have that issue, right? So there are genetic tests available to kind of see if you might have or might be predisposed to have some sort of altered reaction to certain drugs, anesthesia being one of the big ones. And I remember the genetic counselor, talked about that specifically. And it's funny because probably not a lot of people go and get that genetic test, right? And so that's the idea here, where like perhaps you can use this field to sort of predict how she would, or how the fish oil could possibly prevent that, right? But, oh, did somebody just draw that? Did I do that? That green line?
I'm sorry, I didn't know it was gonna go up there.
No, that's cool. No, because that's cool that you could do that. So wait, can everyone do that? Do that again. How'd you do that? Tell everyone how you did that.
There's a little.
Oh no, mine's
can
got a
do
little
it.
pin on it.
Yeah,
I thought it was just gonna do it for me.
Oh, look at that. Wait, what has a pen on it? Your cursor?
It's on
Yeah,
the
I'm on
screen.
my phone. It just got a little pin on it. And it got a pen, highlighter, arrow, color, and eraser.
Where do you, oh, I see, where you hit annotate. Yeah, oops. Yeah, I think everyone can do that. Everyone should try. What happened here? Can you please go back to where we were? Yeah, if you go up on your computer on the top, if I can get the menu to come back, it says annotate. What the hell happened? 1 second. All right, cool. That's cool. Good to know. For some reason, I think I thought you could only do that when you were in whiteboard, but apparently you can do it anywhere. Yay. All right, it's delayed. That's really good writing too. Okay, cool. All right, sorry, that's a little side note there. But that's super helpful actually. All right, now I gotta get out of here. Get out of here and go back here. There's like a delay. What's with the delay? Oh, all right, I should have erased that, but we'll just ignore that for now. Okay, so anything else you guys kind of wanna? Oh, it also lists here. Oh, so it says here, what resources available to provide pharmacogenetic information. I got to plug in my other computer. So just tell me what you guys got for that. What'd you find out about that?
So I said like visiting like clinics made for that and going online for like guidelines and stuff like that.
Okay. What else? What are some other things that you guys wrote down? Anyone?
Be inside of like the supplements or the medication bottles.
Yeah, I don't know if that will have information, but I guess potentially it could.
It tells you what the main ingredients are, like if you are pregnant or whatever, you shouldn't take it.
Correct. But in terms of linking the genetic information with that drug, but you're right, you would need to know what the active ingredients are, yeah. Apparently there is a list. So the FDA maintains a list of drugs to which they have pharmacogenetic information on. And then you can click on that and see what types of genetic information is there. So that's interesting. So we can so it might be a good idea to look that up and kind of see. So I would imagine if you search up like FDA and pharmacogenetic information, there's information on that. I don't know how many drugs are on that list, but that's something that you could refer to. Like I said, it's not going to be every single drug, but so that's pretty interesting. So again, we're trying to really expand this field, and I think it's probably in its sort of infancy right now, but it's definitely the way, medicine is trying to move. It makes sense, right? I mean, even if you just, again, think about my anesthesia example, I'm sure even I would imagine there could be illegal drugs that are on that. I don't know if there's illegal drugs that are on that list, right? But think about it. Like if you think about like overdoses and things like that, you just may have this genetic, change that makes you more susceptible, or you're more sensitive to, even drugs of abuse, right? So something to think about. So it's kind of, it's pretty interesting that we can kind of get that initial sort of predisposition or that genetic information even before taking a drug. Because sometimes it's too late, right? After you take it.
Yeah. I mean, I took a class though on like pharmacology, but it says there's not a lot of testing for like pregnant women and like specifically on how some of these drugs like interact with them. So I don't know, how would that like relate?
that's a separate issue, I guess, right? So true, if you just look at like, if you talk about pharmacology, right? And just look at basic pharmacology in terms of how like a drug is cleared, right? If you look at like metabolics and stuff like that, probably a lot of those studies aren't done in pregnant women. That's probably what they're referring to, right? So there's different ways that a drug can be metabolized. It could hang around longer. The half-life could be longer in pregnant women, and it could have altered effects. And I think that's probably what they're getting at there. But in terms of the pharmacogenetics, it's the idea of you have there's a genetic change that they pinpointed, right, in the DNA that then makes you have an altered response to specific drugs. So you can go get a genetic screen, and if you have that change that comes up, then you probably can't take that drug or something like that. Does that make sense? And in that sense, you still could have some altered response in pregnant women. It still could be slightly different as well, but it's kind of a separate thing, I guess. Right?
Dr. C, is that what's referred to as like personalized medicine?
Yeah, that is totally exactly what it is. I mean, there's other kind of aspects of personalized medicine, but this is one of the big ones, right? Even if you think about tailoring cancer treatments, right? Like chemotherapy and things like that, just to give the patient, maybe the other ones aren't dangerous to the patient, but there might be certain chemotherapeutic agents that are more effective, right? And if you know that ahead of time, then you're going to give that patient that. So yeah, exactly what it means. Anything else? So this is kind of interesting, right? Again, this is why we do these case studies, because it brings up sort of some more interesting issues, elaborates more on what's presented in the text. Again, impossible to like spit out every single bit of information we know about pathophysiology, right? We're just kind of giving an overview, but there's so many more, so many details that we could kind of talk about it with any one given topic. And we just did it with pharmacogenetics, right? In the chapter, I just kind of mentioned it. Here's what it is, and this is personalized medicine, but we really didn't get into it until now. So this could be something like, like things like this, like for the, I guess kind of things that we kind of cover in the case studies. I feel like those are probably, I mean, some of it can come up kind of in the multiple choice questions, but those would probably be like more surface type of questions, kind of just knowing what pharmacogenetics is. And then the question might give you some sort of scenario kind of, and then whatever. But as long as you kind of know what pharmacogenetics is, you probably could answer that fine. But for the essay questions, kind of where we went with our discussion here, I could ask you questions where I'm trying to get you to elaborate a little bit more about it, right? So this is, I guess, is kind of a good example of something that I might use as an essay question on the exam, if that makes sense. All right. All right. So what I want to do is I want to pull up another case study. This case study that I believe, what's his name? John Barrows, I think is the name, because it brings up something that I don't know that I necessarily really like focused on in the PowerPoint. It's just an example of another autosomal dominant genetic disorder. So I just wanted to pull that up. And again, I want to show you the e-text to show you a lot of the resources that are there for review. And again, if I don't cover something, I'm not going to ask you it on the exam. And if for some reason I ask it and then like everyone gets it wrong, fine. That's, I would fix that. But the point is again, if you want to learn more and you want to learn as much as you can, use all the resources that are there, right? So one second, let me just get to, what the heck is that? Kind of annoying the way this is set up, but anyway. All right, so let me just show you this here. So I'm so happy we figured out, we uncovered the annotate tool. All right, oh, actually, I can go into it right from here. So let me first erase this. Okay, cool. And let's go away with that. Okay, so obviously I didn't assign this one, but we're gonna take a look at this case study. So let's read it, and then I'm gonna kind of go back and just show you something here. So just take I'll make it bigger. Just take a minute just to read it, okay? Okay, so I'll leave that. Okay, so take a look at that. So again, this mentions another disease or another genetic disorder. And this genetic disorder is actually brought up in the textbook. Okay, so let me just show you real quick. If we look at this, I just want to show you this e-text here. So I'm in the, I guess you have to have, like I said, you have to subscribe to the MyLab part of it. But if you're in the textbook e-text, you can obviously see all the figures, read everything that's in there. And then if it goes to where I want, it's a little slow. Okay. So one, it'll show you all the case studies here too, right? And then, like I said, there's lots of check your progress questions that are throughout the textbook. If you have this e-text version, you can click on and it will give you the answers. Okay, so these are obviously just little checks on if you know what was presented in the chapter. Other thing I want to show you. Okay, so this is us. We're gonna. Oh, why did I do this again? Wait, 1 second. It's back here. I just wanted to show you. You know why? I know why. I think I just hit it twice. Never mind. I figured that out. 1 second. Sorry, guys. I forget what all right, I think I just passed it again. It doesn't matter. Let's go through the case study. Okay, let's go through the case study and then I'll show you what I wanted to show you guys. But regardless, everything in here is pretty much interactive. So if I go, here's the other thing I want to show you. So if we go to the review questions for chapter 2, let's do that. Okay, so these are the review questions. They are just, if you just have the regular copy of the textbook, you'll find the review questions at the end of the chapter, obviously, right after a chapter summary, okay? And the answers to these review questions are in the back of the book, okay? So even if you don't have it sort of in this interactive way, you'll be able to access the answers. The reason why I went to that case study is because if you look at the first review question, right? Let's read this and let's see what we think the answer might be here, okay? So you guys can read that, right? You guys all see that? So it says, which statement by the client indicates that further teaching is needed? A lot of the exam questions are worded kind of like this, okay? And so what would you guys choose here?
The second one.
Okay. What else? Who else has a... We want to choose the second one?
Or wait, the third one too, it seems really.
Yeah, so further teaching is needed. So there's only one answer.
Yeah, so we need the third one.
The third one.
Well, we all agree, right? I can't pass this disorder on to my children. I just told you, right? This is an autosomal dominant disease, a genetic disease. And so if you can look at this a little bit more, it gives you a little more explanation here. So I did mention, I think, this term variable expressivity in the lecture, and it's mentioned in the book. And it's the idea, especially when you're talking about genetic disorders, that the severity of the clinical manifestations will vary in different individuals a lot. It can really vary a lot. It can be really more serious in one and not serious at all in another, right? So it says here in mild forms, the person may only have a few of these cafe a lot spots, and I'll show you, I'm probably not saying it very well, right? This is what they're referring to, right? So this is sort of just a mild discoloration of the skin, okay? But there are other skin abnormalities that can occur as well that may be more serious. So for the most part, these are pretty harmless, okay? Okay, in more severe forms, person can have more than 100 neurofibromas. And so neurofibromas are actually fibrous tumors of the nerves, okay? And so, like I said, there could be really a lot of them. So the reason why, and then if you go back to that case study on John Barrows, it is pertaining to this disease, okay? So I guess the point I kind of wanted to make was like, you know, the lecture on chapter 2 was an hour and 45 minutes. And I actually didn't even really mention this specific disorder, right? Because there's too many examples to mention all of them. All right. So I guess maybe if I was going to ask you about something like this, or if we think about essay questions, I can use some of these case studies. Like I would give you, the case study text, and then maybe use some of the case study questions, or ask a question from there, right? So then you have some context, because it's not about memorizing, like knowing exactly what neurofibromatosis is, right? But it's about understanding, concepts surrounding it. Okay, so does that make sense? So I wanted to bring that up. I wanted to show you this, but then I also wanted to go back and just pull up this here. Okay, so if you guys look at this, and what about number 1? How would you answer that? I think it's a pretty straightforward answer. What do you think? What are you doing, Mason? 1 second, sorry. What's the issue?
Daddy got charged with bags. They're charging right here.
Okay, well, I don't know what to tell you. When I'm done, I'll help you. Okay?
You put them somewhere.
Sorry. He's worried about chargeable batteries for his controller for Xbox. It's very important. Thank God he starts school tomorrow. All right. Okay. Anyway, what do you guys think for number 1 there?
I think he needs education on genetics and how it works.
Right. So the idea is we want to know that neurofibromatosis is a genetic disorder, right? So if we're talking about a genetic disorder, we need to, see a genetics counselor and know about the field of genetics. Yeah? Okay. What about number 2 there?
That someone in his family has neurofibromatosis.
Yeah, that most likely there are probably other family members that have this disease, right? They just may have maybe more mild forms, right? Again, important to see a genetics counselor, because you probably want to know kind of what the family history is, and to see how many people had it, because potentially it could end up being more severe, right? Or you could see more severe forms down the line. And also, I guess, just to be aware that if you saw some of these skin markings, you would know that that's what it is, right? If you were never aware of that family history, maybe, you would never think of this as being the cause or something like that, right? Okay. So
I have a question.
Yeah.
Before we move on, can a disease be recessive?
Yeah. You mean like a genetic disease?
Yeah, because I think he says that he doesn't see it in himself. Oh, yeah, he has similar skin markings, but okay. Correct. So it's mild.
Correct. So he has it, right? But he didn't really ever realize it because it's mild, right? Does that make sense? But yeah, a disease can be recessive. What's an example of an autosomal recessive disease? I give the same example all the time.
Cystic fibrosis?
Yeah, cystic fibrosis, right? In this case, this is autosomal dominant, but cystic fibrosis, right, is an autosomal recessive disease, meaning you have to be homozygous recessive to have the disease. In this case, for this type of disease, you only need that one dominant disease allele. Yeah. Okay. Also, though, one other thing to bring up here, it actually says in the book that this condition, this neurofibromatosis, it says it has a 50% new mutation rate. And so it says so that means half of the individuals that are diagnosed have no family history. However, that could kind of be skewed if you think about it. So if the cases were so mild in previous family members, there might not be any reports of it, right? So anyway, just kind of a side note to kind of to think about. All right. So anyway, we move on. We can go back to a couple of those review questions. Let's see what else we got here. What do you guys think? What happened here? Okay. All right, so let's go to the next question. So again, these are all in the back of the book. Like I said, I thought about maybe I'll start assigning these as homework, but I don't know. we can just kind of use it as review. So a pregnant woman underwent genetic testing and was told that her fetus has aneuploidy. On the basis of this information, the nurse explains what? What does that mean, aneuploidy?
Isn't it like a loss or gain of an allele or something?
Well, is it allele or what? But you're right. It's changed in number. Of what?
Is it the last
Chromosomes?
Yeah, in the chromosomes. So it's a change in number of the chromosomes. So it could be a loss, it could be a gain, right? But there's an abnormal. So whenever you see this prefix, right, it's an so euploidy normal and euploidy is abnormal. So an abnormal number of chromosomes. So which answer would you choose? See if we're right.
The last one.
Yeah, cells have an abnormal number of chromosomes. Okay. So, right, our big example and the example you see a lot is trisomy of chromosome 21. Remember, we talked a lot about, or not, I don't know that I talked a lot, but gave examples of, you know, aneuploidies or where you have multiple chromosomes in the sex chromosomes, right? And there are a lot of examples there because those are more tolerable than extra chromosomes in the autosomes. All right, let's do the next one. All right. Read that and let's see what we think about this one. That's kind of weird that they would say carrier. So if it's an autosomal dominant gene mutation, it says she's a carrier, it means she has the disease, no? Do you guys agree? So I don't know that I necessarily like the way this is worded.
But doesn't carrier mean that, like, and I don't recall it saying that, like, when I learned it, that a carrier necessarily has it, that they contain it. So they would be heterozygous.
And so if it's an autosomal dominant disease, what would that mean if they're heterozygous? Let me use my tool.
That they contain, like, the dominant allele.
They contain
But it's
both.
present.
Correct.
So they have like both dominant and recessive.
Recessive, yeah.
Correct. But if we're talking about an autosomal dominant disease, okay?
Dominant means they're like showing signs of it, like in the phenotype.
Autosomal dominantly inherited disease, if you have one copy of the dominant allele, you have the disease. Now, there are examples of diseases, like we talked about, kind of like reduced penetrance and stuff like that. It's not always as clear cut as this, right? So like if you're a heterozygous, maybe you have a more milder form of the disease versus like the homozygous dominant. But for the most part, if we're talking about a autosomal dominant disease, one disease allele, which is the dominant allele, means you have the disease. If this said autosomal recessive, right, what would this genotype mean? What would you call this genotype? Then you
would be CC, common CC.
Well, no, if this same genotype, if we talked about an autosomal recessive disease, what about this person? What would be their phenotype? Would they have the disease or not?
No, they would not be showing signs of it.
They would just be a carrier, right? Again, not everything is always this clear cut. There are examples where it's not just pure sort of Mendelian genetics, right? But when you say something is autosomal dominant, you're suggesting that one dominant allele means you have the disease. Does that help, Manuela? So the only reason why I said it was worded weird was because of this saying autosomal dominant.
So then
Okay.
how would you answer this question?
Yeah, so let's see. Sometimes the book gives stupid questions, right? So then we have to like feed through it. And if I put a stupid question like this up, then I would go through it and see, oh, does that really make sense, right? Why did I? All right, so let's see. It says, but her partner does not carry the gene. Okay, so then I guess that means her partner is what? Based on this, it would mean that our partner is recessive, right? Two little C's. Okay, which of the following would the nurse explain to the woman and her partner? Okay, so if we do the cross here, right? I guess I'll do this. I'll put this down here. Let's see. And then we do big C, little c, right? Big C, little c. And then little c here, little c here. So based on my Punnett square here, and the fact that it's autosomal dominant, what's the percent chance the child will have the disease?
25.
This is big C, big C, little c, big C, little c, and these are little c, little c.
Okay.
What is it?
So Dr. C.
Yeah.
Every time we have an autosomal dominant, it has to be heterozygous dominant.
Yeah, that's what I was gonna ask.
No, if your genotype is this, you have the disease. But if you're homozygous dominant, you also have the disease. But
How did we know?
The reason why I put that there
How did
is
we?
carrier. It says carrier. See that?
Okay, got it.
Like I said, I don't like that
didn't pay attention to
term
that.
carrier, but that's why they're saying that. That's where I got that from. Does that make
So
sense?
if you were to use the term carrier, would that be indicative of a autosomal recessive?
Usually, yeah, usually, right? Because it's the idea that you don't have the disease, but you're carrying it. So yeah. So like I said, I don't like this terminology, but that's what they're referring to. They're saying you have one disease allele and one normal allele. Does that make sense, guys?
So if they didn't say that she's a carrier,
We would,
it would be two big C's, right?
right, or this.
And
could
she'll be
no,
and she'll be having the disease.
correct. She has the disease now.
Okay.
Wait, I don't get it. So like carrier, wouldn't that mean
You
like
guys
she?
didn't have. These are all the people that didn't have genetics yet. Go ahead, say it again. Who's that? Berlin. Go ahead.
Like, so for right now, like I see that it says carrier. So like carrier means that like she has it, or it's just like in her.
Carrier, so I guess if you want to, let's take it as the most general way to interpret carrier. Carrier means that you have one disease allele and one normal allele, okay? In this case, the diseased allele, because it's autosomal dominant, is the dominant allele, right? So if we use the term carrier and we talked about, autosomal or a recessive disorder, it would be the same thing. This is still the same genotype, this heterozygous genotype. But for an autosomal recessive disorder, a person with this genotype, right, a heterozygous, would not have the disease because the disease allele is the recessive allele. The dominant allele is the normal allele. So it sort of masks or compensates for that recessive allele. If the disease is autosomal dominant, like it says here, and you have this heterozygous genotype, having just one dominant allele means you have the disease. Does that help?
But how did we know that it's a heterozygous dominant?
Because she said carrier. It said carrier.
And if it wasn't carrier, we would just assume that it's two big C's?
No, you wouldn't know. You would, if it didn't say carrier and it just said she has an autosomal dominant condition, right? What would be the two possible genotypes?
Big C, little c, and big C, big C.
Correct.
Okay, so Dr. C, I'm a bit confused. So which one means that, or which, is it the big C or the small c that represents the disease?
In an autosomal dominant disorder, what's the answer to that? Somebody answer that.
So the big one.
Big C.
Yeah. If it was an autosomal recessively inherited disorder, then which one would it be?
Little c.
Little c.
Yeah. Does that make sense? Does that help?
Yeah.
Yeah. So, okay. So based on my Punnett square down here, what's the answer?
50%.
50%.
50.
Oh, and it's right. Now, I guess I wouldn't word the question this way because again, the carrier is kind of misleading. I might then put in parentheses, the genotype is heterozygous or something like that, just to kind of clarify. So again, if something was worded this way, it would have been confusing because it's autosomal dominant and saying carrier. Usually when you use the word carrier, you're still referring to a heterozygous individual, right? But the idea of carrier is that they're normal, they don't have the disease, but they're carrying the disease allele that then can be passed on to their offspring, okay?
And then that would mean that the small one would be the disease one. Like
correct.
When they say carrier. Okay, that's why I'm confused.
Well, right. So if you're talking about an autosomal recessive disease, right? What about these two genotypes? Would the person have the disease or not? Autosomal. No. So the only genotype, I gotta go back. The only genotype that would have the disease would be what? Little c.
Two little c's.
Okay?
Okay. The wording is weird. Okay. Got it.
Yeah. It's not, again, and nothing's ever straightforward because like I said, even though we say, something's autosomal dominant, you still have these issues of like the reduced penetrance and the sort of, right, the variable expressivity that we talked about. And so not everything is always so clear cut, but if we want to understand autosomal dominant versus autosomal recessive diseases, we just went through all of that. We should all hopefully understand that. All right, let's do one more, and then unless somebody has another question.
Wait, would it work if she was like an asymptomatic carrier? Do they? Because in that sense, then it would mean like she doesn't have any symptoms, but she's
But again, if you're
infected.
talking, yeah, correct. Like, so she could have the disease but be asymptomatic, not even know she has it. If we're talking about autosomal dominant, yeah, that's what I mean by like those concepts, like reduced penetrance and the varied expressivity, right? That's the case. But bottom line is, if you're talking about an autosomal dominant disease, a person that has one dominant allele has the disease. In terms of what symptoms they express, or if they know they have the disease, that's a different story, right? Okay, there's going to always be variability in there. Does that make sense? Again, nothing's ever clear cut. That's why you always need doctors and scientists. All right, let's do one more and then we're done. Let's see here. Genetic testing indicates that one partner has an X-linked disease. The nurse explains that what? Like I said, some of these questions aren't, I don't know, they're not worded the best, but whatever. It says will.
It would be the first one. That's
The last be the last one.
Yeah, so it's the opposite. A female has 2 X chromosomes. So if we're talking about X-linked, most of the time it's males, right? They most of the time show up in males because a male only has 1 X and 1 Y. So if you think about the diseased allele being on the X chromosome, and you're a male and you only then have the Y, you don't have a chance of compensating for that disease allele. If you're a female, you have 2 X chromosomes, you can have the disease allele and then the other one can compensate and be normal, right? So for the most part, males will have this. And so you'll pass it, it'll be more likely that a male or the son will inherit that disease. Now, it's kind of weird here, right? Like which one you're a son will inherit the disease from his father. A son will manifest the disease. Huh? Which one are you going to pick?
The last one?
The second one?
The second.
Yeah, see, I'm expecting that we kind of would have the two. So not a son wouldn't necessarily inherit it, increased chance, right? And I guess, I don't know, both of these are kind of weird. So I feel like both of them are the right answer. So which one do you want me to pick? Let's see what they say.
The second one.
No, it will be the last. Yes.
So you can read a little bit more about that. So again, if I usually tease through these kind of weirdly worded questions, and I would have modified the question so that the answer choices, there was only one clear answer choice. So to be honest, I don't know which one.
Wouldn't it be the answer because you can only pass it from your mother?
From the mother, yeah.
Oh, sorry, wait, I missed that part. A son will inherit the disease from his father. Yeah, I mean, right, exactly. There you go. I missed the inherit the disease from his father thing. Duh. So important to read all the answer choices, right? Because if it's X-linked, the only way the male is, right, it's getting the X chromosome from the female, Y from the male, right, from the father, Y chromosome. I don't know, is that necessarily true? I don't know that that's, I don't know. Regardless, it's
it
still
says
confusing.
it in the feedback part.
Yeah.
Professor.
Right.
When I go to open, I will be able to see the feedback. Maybe when I go to my Moodle.
For what?
Maybe I want to revise these ones. I will see even the feedback of.
This isn't in Moodle. This is in the e-text of the book. If you go into like the MyLab, that's why I'm saying it's kind of useful to have this, but we'll kind of keep going through that.
Wait, what if the father has this still? It still can't be
passed?
Because it's passing on the father's giving the Y chromosome to the son.
Oh, okay. So
right?
even if he had this, it wouldn't work.
Yeah, that's what they're saying. Yeah, right.
Can you send for
And
us?
in that case, Dr. C.
Mhm.
Oh, nothing.
Go ahead. You have a question? No.
I want to see those one later.
Then you have to purchase the e-text version of the book and or just the MyLab subscription. Yeah. Like I said, I can't, there's no way here. Let me see. Oh, I wanted to try to sign in and just show you what I meant by that. Yeah. So like if you subscribe to this MyLab, then you have access to all of these things. There's actually even extra questions here. For some reason this never doesn't open on my Mac. I got to figure that out. But where I was in this e-text over here. Yeah, there's no way, I don't think there's any way of me, like I said, there's no way of me sending you that link. You have to access it through here with a login. So the best we can do is really just go over these and use these as review. If you want to go over some more of them, then I guess let me know, like during office hours, we can go over them. Like I said, I also may put them up as homework questions, but you're not going to necessarily, and then I guess I could copy paste in the answers somewhere else. But honestly, like there's only so much, we could do here. So that's why they provide this sort of extra stuff like this, because obviously they want you to buy it. Because I think it is definitely helpful, but I'll make sure we always do these review questions moving forward. So if you really want them or whatever, I guess reach out to me and we'll kind of, I don't know, I can kind of think about a better way of kind of putting these up on Moodle or something like that, see what I can do, but I can't make any promises. All right. All right, guys, we are done. So be on the lookout for an assignment with that genetics and COVID article that I'll put up. And I'm just going to ask you guys, I'm not going to I'm just going to ask you some specific questions pertaining to the article, put it that way. Okay. Rather than the kind of journal article summary thing that I used to do and ask about the hypothesis and things like that. I'm just going to ask some specific questions that are related to the article. And then let me just see if there's anything else.
Do you have any idea when that'll be due by?
It'll be due by, I'll probably make it due next Wednesday. I'll give you guys a week, okay? Other thing, heads up, there will be another quiz at the beginning of class next Wednesday, okay? On chapters 2 and 3. So I will put up a recording for chapter 3. Honestly, chapter 3 is really not that dense. It's just it's environmental factors that affect essentially, pathophysiology. So I'll put up that recording and then we will be starting chapter 4 after that. So your first exam will be on chapters 1 through 4. So right now for next week, we're going to have a quiz on chapter 2 and 3. I will assign another case study for chapter 4 that we'll go over. And then your exam 1 is scheduled for that Monday, I guess, right? Again, remember, because I'm keeping Monday as the virtual day. So I'm probably going to always have your exam scheduled for that day. I don't want to waste one of our in-person days if everyone has to take the exam remotely. Okay. So that's kind of heads up on that. I don't know. So for right now, listening to the lectures, right? And the review sheet, writing in, and taking notes on that review sheet. I will be putting up an assignment for that you guys are going to be submitting that review sheet. Okay, go ahead. Question?
You said that we were going to be in person next Wednesday, or is that not? Yeah, so we would be taking the quiz in person.
Well, yeah, those of you that are in class, you'll be logging into Moodle and taking the quiz along with the people that are virtual. Okay, everyone's gonna be doing it at the same time. It all worked out when I have more students. I have like 35 students in nursing and they were all fine taking the quiz all at the same time. So we should be fine. Although, yeah, I mean, not all of us are going to be on the school Wi-Fi anyway. We'll see how this works out with the in-person or whatever. I mean, look, if it turns out I'm showing up on Wednesday and there's 2 people there, I don't think that's fair to me for me to be sitting in a classroom with 2 people, right? So let's see kind of how that goes. But I also want to give you guys the opportunity. Plus, I'd rather be teaching live as well, right? It's not this isn't the obviously most ideal situation. So we'll go with that. So Wednesday, like I said, I'll let you guys know where we're going to be meeting. That's the only question. Okay. So do you guys want those do you think it's helpful if I assign those questions, those review questions as homework? Yeah. All right. I can do that.
Yeah.
I mean,
Sure.
all right. I think it probably is helpful, to be honest, as I was kind of, because those are more in the style of the exam questions, to some degree. Okay. So I'll work on getting those up, like I'll get those up for you. And that'll be another kind of extra assignment that'll be on there. So for right now, right, listening to the lectures, taking notes on your review sheet, be on the lookout for the journal article, and then we have a quiz next week. So if I put up some review questions, those may be also due next week as well. Okay, so.
Would you send out an announcement that lets us know that you've posted all these things, or?
Most likely, yeah. Yeah, especially if it's like another assignment that's due. I'll make sure I tell you guys. Yeah. I mean, I usually in general on Fridays, I think I did that last Friday, or after our class today, at some point I always send out a sort of reminder, here's what's upcoming, just to kind of make sure everyone's on the same page. Yeah. So I usually will do that every week. Okay. All right, guys, if you don't have any other questions, you can log off, but otherwise I'll stay on too.
Thank you.
Yep. Bye, guys.
Thank you.
Thanks, guys.
Thank you, Professor.
Welcome. Have a nice day. Bye, guys. Have a good one. Oh, Blossom, I know we have to talk real quick, so just hang out. Fabi, do you have a question?
Yes, about the research.
Oh, yeah, that's right. Okay. All right. Hang on for a second. Rachel, you have a question?
Yeah, I had a question about like what we were just discussing. I was trying to find answers on my phone. But let me see. Okay, so for the it was regarding the last question with the X-linked disease. So what I kind of learned just now is that one of the X, I guess, chromosomes, they're like inactive and only the other one is active in females, correct?
Correct.
But in the male, both the X and the Y are active.
Correct.
Okay, that makes sense.
But it's not, whatever.
Because I don't know. The
Not
way how,
as clear cut. So there's not, yes. So not every single gene on the other X chromosome is inactive, put it that way. Okay. But there is,
except for the egg ones. That's what I saw.
Yeah. So again, yeah, don't read too much into that, but there's other things that go along with that and mechanisms that are involved with inactive, like X chromosome inactivation and blah, blah, blah. It's definitely more complex rather than just thinking the entire X chromosome is totally inactive. That's not necessarily true either, but yeah, but you're right to some degree.
Okay.
Yeah.
And then for the females, right, they have two X. One comes from the mother and one comes from the father.
Correct.
Right? Okay, because a while ago it kind of looks like only the father gives a Y. So I was like,
correct. But if it's a male, right? If you're
then it gets
son,
that
the
Y.
Y had to come from his father and the X had to come from the mother, right? So meaning if the male had the X-linked disease, right, and has a son, there's no way to transmit it onto the son because he's giving the Y chromosome to the son. That makes sense?
Yeah.
Yeah. Yeah.
Okay.
Right? Thanks.
All right. Thank you.
Thanks, Rachel. All right. Fabi, so for research, I gotta talk to Blossom about something, but for research, I mean, I'm more than happy to try to set stuff up. They're still giving out, like TriBeta, you can still put in a, whatchamacallit, an application to get money. They're still moving forward with that to do independent research. So I don't know, what are you thinking? And we could start, I mean, we could also start it sooner rather than later, but we also, I don't know if they're kind of like delaying things. They actually just sent an email, so I got to look into that a little bit more.
Okay.
But I do know you can submit, and it's due like at the end of the month or something like that, but you can submit applications, grant application. Now, So anyway, if we're really gonna do a research project, we would still put a proposal together and submit it, whether we got it or not. I mean, that's usually the caveat and the kind of the rule, right? Everyone needs to do that because it also sets a framework for what we want to do.
Okay.
So I don't know, think about it a little bit more. I'll put this out there to you. I am working on a project right now at the VA involving traumatic brain injury and suicide. It's in an animal model. So the behavior that we're looking at is like a behavior that measures impulsivity, with the idea that that impulsivity could connect to your propensity to commit suicide, right? But we're looking at molecular stuff, like doing RT-PCRs type stuff. So you could totally kind of jump in on something like that if you just, I don't know, unless you have something else in mind, that's fine too.
I actually don't have anything in mind. I just wanted to like ask you about it and see what your opinion.
Yeah, I mean, you can do it. It's possible to do a project, and if you're kind of want to get that experience, I would say, yeah, let's talk more. We can talk more about it. So think about what I just told you, and then think about if there's something else like that you might want to do a project on, or kind of what sort of field it might be related in, and then we can talk more.
Okay.
All right. All right. Cool.
Cool. Thank you.
Got it. All right, so Blossom, the in terms of the accommodation, there's nothing on there that I see that I would need to change for you right now, because I provide all the notes, I provide all the recordings of the lectures. It's not extra time on the exams or anything like that.
No, it says 50%, but it's just like if I were to need it. Yeah, it does. I can send it to you again.
Okay, let me look at it, or I can look at it. I think I have it in my email. That was my question because I didn't see it.
No, I never send it to you because usually I'm fine. She just told me that I should send it to all my professors in general, in case if
all right, sorry, I do see that. I don't know why I missed that. Extra time on tests and quizzes at 50%. So there is a way for me to set that actually individually on Moodle.
Okay.
So again, I mean, you're not going to be taking those, nobody's taking an exam in the office separately or anything like that right now, right? All you guys are taking it remotely anyway. So what I can do, like I said, is I can set your time specifically to have increased time. Okay. Quizzes is probably usually not necessary.
Yeah.
But I still can add some extra time on there. So I have to I guess, can you it may be helpful if you kind of remind me or just say, hey, because I have to manually each time go in there. And I'd like to say that I'm going to remember, but I may forget, and then I don't want it to, you know what I mean? Like, I don't want it to be set and then you didn't have that extra time when you should have. Okay. So remind me about it. And then I'll make sure I change that setting. But in terms of the other stuff, I don't think there's really I think everything that says there,
everything else is the same.
Okay. All right, that's cool. That was my question because I didn't see that, but now I see it. So never mind.
Thank you.
Okay, bye.
Bye.